Well, I think we'll get started, and of course, if people trickle in, that's all good. So my name is Martin Wegman. I just want to introduce myself. I'll be moderating the panel today and kind of sharing some slides in the beginning. I will kind of let each of the panelists introduce themselves in a little bit, so we'll get to that momentarily. But I'm in Florida at Orange Park Medical Center, and excited to be here to kind of have this conversation with the audience here and kind of try to move the science forward on this topic, which I think is a very important one. So no kind of financial disclosures to report here, other than the fact that all of us here on this panel and moderating are employed or paid by the various for-profit entities that we're going to be talking about. So you can take that as you might, but no kind of additional disclosures beyond that. The objectives for today are really to, one, unpack the scope and some prototypical structures of graduate medical education programs, particularly as it relates to kind of the ownership structures of both kind of the hospital that's sponsoring them, as well as the residency faculty structure and ownership structure for residency faculties, because they are different, and we notice that there's a lot of kind of misconceptions in that space that I think it's important to clarify so that we can have kind of rich discussion around it. Additionally, we want to talk about the challenges and potential benefits of such programs, and then also kind of discuss kind of differences between different program sites. So I think it helps to start with any conversation about all of this is to start with what's the end, what's the goal of everything we're trying to do in graduate medical education, And I think the ultimate goal is to promote optimal societal health and medical need fulfillment for our society. Really, that's what the purpose of what we do day in and day out as a GME program, GME faculty, is to train the best doctors possible that will meet society's needs. And that's both from a specialty perspective, but also a distributional perspective, from like geographic distribution perspective. We want people to fulfill the needs of society in providing medical care. And so, I think it's important to keep this in mind as we're having this conversation is kind of, is there an optimal model? And I consider the variety of models really, and kind of what are the pros and cons of each. So that is what I hope the discussion kind of touches on today. We'll start, I think, this is a kind of interesting audience engagement. Just curious, show of hands, like how many people in this room are working for a CMG or for-profit entity? And it's okay if people are like this, yes? So excellent, okay. So it seems about half and half or so, maybe if I just raw estimation there. Just to provide a little bit more context to the conversation today. So this is data that comes from Ivy clinicians as well as the Lown Institute, which in a talk later today, I'll be sharing some data on Lown Institute. But if you care to, these data sets are both available publicly, and this is my own analysis that shows you the major employer groups for the faculty of EM residency programs across the country. And the unit of analysis here is the residency program, not the number of residents. Just important to note that some residencies can be quite large and some are relatively smaller. This is focused on just those that are national clinician partnerships or corporate owned. I have not included kind of individual groups like single group practices or like small group practices or hospital ownership. All those are mostly one-off, mostly kind of one-off kind of ownership of or sponsorship of GME programs. But as you can see, Team Health, CMG, basically meets the definition of CMG, about 30 GME residency programs to the faculty staff. And then Envision, which, as most of you know, perhaps Envision's undergone bankruptcy proceedings and is now, many of the sites that are affiliated with HCA actually have kind of been folded into into HCA, so now the faculty are becoming hospital employed actually. So, but just so you know, a variety of their groups here, just to share kind of as a context. And then also from the perspective, and I'm going to kind of draw this distinction in a few different ways, is that there's also the hospital ownership and the hospital sponsorship of the residency program. So you have a faculty group that kind of, that teaches the residents and does most of the teaching clinically as well as on didactics. And then you have the hospital that sponsors and kind of owns the residency program and usually usually pays the resident salary. So kind of there's multiple entities involved in this process, and hopefully we can kind of unpack that a little bit here today. But just to clarify, this is all residency programs, EM, specifically residency programs across the country. And this is just breaking down kind of ownership groups, essentially. So nonprofit ownership groups, which mostly kind of just run one EM program, but some are larger and run multiple. And then, public ownership of residency programs, HCA, with approximately 19. This is 2022 data, I should have clarified. So a few more since that time. And then you can see some other kind of corporate players as well. So why the controversy, right? I think it's been, there's multiple reasons why there's been a lot of scrutiny about corporate influence in medicine more generally. The focus today is really on, corporate influence and corporate sponsorship of GME programs. We can kind of, I think that first kind of, the first point, it can be debated at large, and we can kind of have another controversial session on that maybe next year if we decide. But the focus here is on GME programs being sponsored by corporate entities, and kind of what might be the disadvantages or advantages of such situations. I think there's multiple reasons for why there's such controversy around this. I think a lot of it stems from, one, just kind of general dissatisfaction in the specialty, decreased agency or autonomy, however you want to term it, in terms of kind of increasing influence by others beyond the physician, in terms of what happens at the bedside. This has been a product of many factors, and that's a long conversation, but certainly kind of, I think that's an important contributor. Certainly the pandemic brought all this to a fore and also increased the consolidative kind of forces at play. And then kind of, I think nobody in this room isn't aware of kind of the workforce questions and concerns that arose kind of right in 2020, and then kind of have continued to kind of raise questions around, do we have too many positions, not enough positions? What does the landscape look like? I know initial workforce report estimates suggested we're going to be oversupplied quite soon, and then kind of now kind of backing off of that a little bit and saying that, well, our attrition numbers were underestimated, and distributionally we're not doing so well, especially with recent legislation in Virginia and Indiana that now requires a physician on staff at all times at all EM sites. So there's been a variety of kind of changes or kind of new understanding of the workforce issue that we can kind of unpack, but that's not really the purpose of today. But I think it dives into why there's such scrutiny on corporate influence, because some kind of see that as the target or the reason for some of these problems. And I think it's fodder for discussion here today. Fortunately, there was some bounce back, from, I think, what was it, 18% unfilled to now 5% unfilled in terms of our match rates. But no doubt that this fueled kind of the scrutiny and focus on the expansion of residency programs. This is Brian Carmody. If you haven't read his stuff, like, super great. He's, what is he, the sheriff of sodium or something? Yeah, I think that's his he's like, just go to his Twitter and his website and review his stuff. It's great. Okay, so let's get into a little bit more specifics here. So, one thing that I wanted to cover, and then we'll kind of break to the panel and hear about their structures and kind of how things arranged for them, is the relationship between the residency program itself, the faculty groups, and the hospital. Because I often see this as a misconception, particularly in like Reddit feeds or like people that are unhappy with CMGs, is kind of blaming CMGs as the cause for all this. And I think what you'll see today is there's so much more nuance to it, and that CMGs aren't really the leader in GME per se, even though they employ the faculty. It's often the hospital systems that are sponsoring this that are actually driving most of the work. It's important to kind of distinguish. So let's see. So, I think the overarching point here is that there's a lot of heterogeneity. This is very nuanced. So to say kind of one thing is bad and one thing is good is probably not the way to go about this, because everything is very complex, and there is many different structures at play. And so I think it's important to be nuanced in the language that we use to say, maybe this structure is not advantageous, but this structure may have benefits, or, I think it's helpful to do that. And we can just describe it more, discuss this more. But so I think, when we're talking about this faculty group ownership and organization, it's important to talk about who is the resident employer, who's the sponsoring hospital, and who owns them, and how does that arrangement affect the residency program. Also, of course, you have to think about off-service or secondary sites of clinician training, and then the relationship between all these above, and who is providing the academic resources, the non-clinical resources, who's providing the funding for research or travel or, food even, who is doing all this. So these are all important things to consider and think about, and kind of determine where the resources at, how much are being provided, is it supporting that ultimate goal of training kind of the next generation of physicians. This is my own graph. Sorry, it's quite small in this big room. The slides are available, though, I believe, through the app, so you can see this all. This was kind of my attempt at explaining kind of why this is not just a straightforward CMG, versus not kind of situation, because you'll see at the top there's a hospital owner that's distinct from the CMG, right? Contract manager groups by definition are not hospital employed groups, and so you have a hospital owner who's usually the sponsor of the residency program, and they're the ones that pay the resident's salary, and it is not typical, let me just clarify, in most of the corporate structures, the for-profit corporate structures, there's often different groups that employ the faculty and employ the residents. And so that, may have implications, but it's important to understand that. So at the hospital ownership level, you can have a governmental owner, you can have a private owner, which could be for-profit, could be include a publicly traded for-profit company, or a privately held for-profit company, which includes private equity or not private equity, and then you can have non-for-profit owner as well. You can also have another dimension of that hospital owner, which they can be university affiliated versus not as well. And then at the faculty employer level, there's various group structures, which, hopefully many have been exposed to or know something about, but, you can be directly employed as a faculty member by your hospital. You can have, the government entity that's owning your hospital can also employ you. You can have a contracted group, which can be a Democratic contracted group, like a solely Democratic contracted group. You can have non-Democratic, but predominantly physician-owned groups, which are many of the groups that exist out there do not have a purely Democratic structure. And then there's also non-Democratic, predominantly non-physician-owned groups, which comprise many of the CMGs, and those can be publicly traded or privately equity-owned groups, right? So there's so many different permutations of this, and it's important to kind of bring this into the discussion because those factors could or may not influence things. So. And then additional layer to that is there's possible administrative or bargaining layers to the above. For example, you can have unions, or you can have you can have groups that kind of bargain with different entities within this. So complex, important to understand, I think, in this conversation. And yes, I think I've made the points I want to there. And then, the point I want to make on this slide is really, well, it kind of discounts exactly what I was just describing. All these structures exist, and I think there's importance to that nuance, but also the fact that many non-for-profit institutions operate financially like for-profit institutions. And I don't think this is a surprise to anybody, really. But if you look at the numbers, for example, let's start with the Jenkins and Ho article in Health Affairs this past year, showing that for every $1 increase in profit, you basically see similar increases in cash reserves in comparing for-profit and non-for-profit institutions. So every dollar of profit that a non-for-profit makes goes almost like $1.50 or $1.8 goes into their bank account and gets saved up for buildings or paying out their executives or other things, right? And some may not be aware of that, but very little goes towards charity care, at least in some of these analyses that have been borne out, or towards kind of things that might be considered altruistic benefit. So it's important to understand that and recognize that just because somebody has shareholders that they have to provide profit to doesn't mean that non-for-profits are operating in that fashion. And we're happy to kind of unpack this more. I don't think I need to discuss this piece here. So I think with that introduction, we can start kind of jumping into some of the questions for our panelists. And I just want to start with just having them each introduce themselves, and then also if you guys could touch on your structure at your local shop. Yep, and we'll just start there.
Well, good afternoon. I'm Al Tirado. I'm actually the program director at ACA Florida. I have such a long name, but it's ACA Florida USF Morsani Oak Hill Hospital. We have a very interesting support system. So I currently am employed by Envision until, by the way, May 31st. Okay, because June 1st we are going to be transitioned to ACA. So currently that has been the driving force for the last 6 years. And obviously, our residents are basically paid by the hospital. So literally, it's HCA pays the residents fees and dues. I've been now program director for like 6 years. I've been in GME for 17 years. Before that, I was in a non-for-profit, and I'm very happy to be here today. So.
Hi, I'm Christine Miyake. I'm the program director for the EM program in Las Vegas. So I work for Envision, but we contract with UHS, or in our little local area, it's VHS, which is Valley Health System, but UHS is the mothership. So UHS employs our residents. They actually are the sponsoring institution for the residency program, and they provide all of the support for that part of it. The faculty are still paid by and only by Envision. So, and as far as I know, we're not changing, but I guess that could come down the road. But at the moment, that's our structure.
Hi, my name is Jen Chapman, and I'm the program director at HCA Florida Orange Park. I am an independent contractor with Team Health. Our residents also are employed by HCA. I also have an employed administrative position with Team Health as well. And our faculty are circuitously paid by HCA. We do not currently have any plans to switch over to PSG, but you never know. And that's it.
Hi, everybody. Jason An. I am the EM Program Director for Riverside Community Hospital, which is in downtown Riverside, California, in Southern California. We have kind of a unique structure in that our faculty group is through Vituity, which is a large democratic group. And for those of you guys who don't know, Vituity kind of started as a EM group, but now has expanded into multiple other specialties. And so the faculty group belong to Vituity. The hospital is owned by HCA, and they also employ the residents. But we also have an academic partnership with UC Riverside School of Medicine, who does not have a big academic center. So by default, we kind of serve as their academic medical center, and all of our faculty have appointments through the medical school. And so that's kind of the structure that we have. And I'm also the DIO at my facility, which we'll get into here in a little bit.
I'm Steve Nazario. I'm the program director at Advent Health in Orlando. The attendings are part of Team Health, and the residents are all paid through the hospital, through Advent Health. It's not the way the residency started. We actually started the residency in partnership when my group was a small democratic group. Dr. Tirado was part of that inaugural faculty with me, and we had a bit more independence, and then 2016 we were acquired by Team Health and became a different entity.
Thank you all for introducing. And I failed to mention that I'll be putting QR code up a little bit later for audience questions. We have some kind of pre-canned questions, which I think you will find to be your main questions. So hopefully we touch on some of the main questions. And actually, let's just jump right in. What influence does CMG have on training at your institution? And let's begin with Christine, if that's okay.
Of course. So the corporate management group at our institution, I think, has been actually kind of a good thing for the way we run our program. So our residents are not required for service. We're a large hospital system. We have 6 main hospitals and 6 freestanding emergency departments, and we have 8 residents per class, so we literally can spread them across Las Vegas Valley. They get a varied amount of training, giving those different facilities, so they get to see some of the larger facilities, they get to see some of the rural facilities, and I think it's been a good thing because we are such a large group. It's easy for us to have the residents on with very specific faculty that are really good teachers, and the residents don't have to stress and worry about if they call out sick, then they don't have to be on call for sick call, because our hospitals are staffed as if they were no residents at all. So the residents could all walk out tomorrow and nothing would change in the terms of our flow and our volume and the number of attendings working. So when a resident is on, it's just a great thing for the attending. The attending's like, oh, phew, okay, I can see a few less and just spend some time teaching. And otherwise, we would just be seeing the patients ourselves. So I think that's been a little bit different model than some of your single site large academic centers. And so I think that's really kind of impacted the residents' well-being. I think it makes it a much easier program for them to tolerate. They can actually make their own schedules in a way. Now, obviously, there's certain ACGME guidelines. They can't violate work hours, but they can, I need, these 3 days off because I want to go see my family. Okay, we just put them on different shifts, and we have plenty of shifts to put them on. So I think it's been a really great thing for our residents and the way our program has run. Did you want to?
Yeah, Al. Yep.
Sure. So as I explained earlier, our residence is a community hospital. So we currently have 6 residents per year. And we are structured a little different. So when you ask me about how CMG actually, what do they do for us, besides just helping with some of the stuff for graduation and contracting the faculty, that's basically the majority of what they do, right? We are only in 2 sites, primarily, and we cover the majority in one specific site. So we do have a little bit of a difference because our residents basically are in one primary site, right? So we run a little more traditional. Our residents, basically, we try to keep 3 classes all the times that we can. I guess the difference is that the faculty still sees a lot of patients by themselves. So we never changed the coverage for the ER. We did do a couple of things different because we wanted our residents to be able to pick up patients first. So our mid-levels, technically, we kind of hold a little bit on them so they can still pick up some of those patients. But we never eliminated the coverage or did anything different. A little more sense. Anybody else wants to?
Yeah, I have a little bit. One struggle that we've had that was placed in was because of the 4s and 5s, the medical directors and their focus on getting those patients in and out of the ED and not wanting to have a resident have to wait, present, see the patient, and add to the time. That's been our toughest nut to crack, that we've had that one, where now the simple procedures, right? They're great in resuscitations, they're great at end-of-life conversations, taking complex patients. Nail bed lack, they don't know what to do with. A fingernail, it's like the seemingly simple thing that a PG1 would learn in their first 6 months. It's kind of like I have to look for those opportunities for them. So I have to fight to get them into that sort of routine. It's a back and forth. I have a little bit more pressure that's put on me when I try to sort of have that on. And for the last, in the time as a PD, that's been one of my biggest pushes, is that when they're off, they're off. When they're coming off the schedule for wellness or for an APE or some other residency-sponsored event, that's not my problem. Staffing is not my problem. That's somebody else's problem. I give them enough headway, and they have to staff the ED to make shit. So they always have to put in an extra person or 2 to cover the loss of their residents, as they put it.
I appreciate you bringing that up, Steve. So I think that dovetails nicely into kind of the question about metrics and, like what role does metrics play, and I think it's probably no surprise that CMGs, there's a lot of more increased focus on metrics perhaps than maybe not. And I hope some of you can comment on that specifically if you've switched maybe group structures or things like that. It'd be interesting. But what influences do you feel that has?
Yeah, as far as metrics for our group, metrics are a thing that are going to be out there in the real world no matter where you go. And so our residents are exposed early on to what metrics and what they mean and what goals we do have. And so they're definitely not hidden to the residents, and they are something that we do still look at and abide by. So I know there's been a lot of controversy about OCMGs are only metric driven. That makes it hard on residents to learn if they're only metric driven. And it's not that they're only metric driven, but it is important. And so it is something that we do have to deal with, and we do have to emphasize that to the residents. So I think it's incorporated nicely into our training, and I think it's actually helped our residents when they do get out there in the real world and they're an attending, and all of a sudden they get their metrics, and it's not going to be a surprise to them when they're, hey, your door to dock time's 30 minutes or your door to dock time's 40 minutes. It's way too long. You need to decrease that. That won't be a surprise to them because those are things they're already exposed to now.
Following up on that, I trained at a large academic center in Brooklyn that I loved, and no one cared about metrics there, like nobody. And patients would wait in the waiting room for 9, 10 hours. Nobody cared. So, I think each group is different. We definitely try to focus on the metrics that improve operational efficiency, that improve the quality of care. If we tweak some metrics, if we work on some metrics, that's going to be the difference between seeing another patient in the waiting room or seeing them back in a bed. So we kind of try to give an education to our residents, like Christine said, about what the real world is, and also kind of dispel the idea that all metrics are bad. All metrics aren't bad. Some metrics, if used correctly, can really improve quality of care.
As we're on the topic of quality, and kind of, I think, another big concern is that these programs are not providing quality education, maybe due to the fact that some of the faculty are more community docs, maybe don't have a rich academic background, or, that they are, more, I'll use the word cheap labor that, I know we've heard, and hoping that, Christine, I know, yeah, but yeah, Steve, go ahead, you can take, yeah.
One of the strange things, right, was, let's say 25 years ago or so, we just had the academic centers, the large tertiary care, level 1, everything. We were not preparing them to work in the 3,800 other EDs that don't look like that. And that was the feedback we were getting from employers, right, that, they need to learn how to be nice, think on their feet. They don't have every subspecialist that they can call. And that's sort of that gave rise to the smaller community-based programs. Having been one of the younger ones, right, at the time, in 2007 when we started ours, it was sort of like the backdrop was everyone else was a big tertiary care center, yet we were starting to try to teach them how to practice in the rest of the United States. And now there are more programs that look like my program. So it's been a win when I get employers calling back and say, thank you, because this one has been running circles around, and then he gives me other high names. And I'm like thinking, that's good. That means I taught him well, right? That means that we taught him how to operate in that kind of facility that doesn't look like this one, but looks like that one. So we've been delivering. We have the same deliverables, right? We have the same agency looking over our shoulder, attesting to what you need to make sure that they get across, right? That's the ACGME. And all our credentialing, all our stuff, we have to do all the right things and teaching them that, plus metrics, plus patient satisfaction, plus I don't want to get that C-suite phone call in the middle of the night. I don't want to get, the urologist who will always ask me about why a straight cath urine wasn't ordered, and I'm like, really, do we have to have this conversation again at 2 in the morning? But those are realities of medical directors everywhere, and we can sort of impart that to our residents. And I think we've done it very well.
Yeah, and I agree. I think that our program is really teaching residents how to practice in, 98% of the ERs that are out there, and they don't need to see that unusual zebra that everybody always talks about that comes into the academic centers. Oh, well, they didn't see this, unusual zebra that you would only see at one academic center once a year in the country. That's not the point for EM, right? It's just to be ready and prepared to take care of all these patients and to understand that you have to you might find those zebras, you have to rule out those zebras, but they're well prepared to take care of it, even if they've never seen it. They're well prepared for that. And so I think we do a good job of that. And I know there's a lot of controversies for procedures, and I know you wanted to kind of touch on procedures, so.
Yes, so when it comes to procedures, it's a real benefit being in a community program, regardless of whether it's for-profit, not-for-profit structure, simply because you don't have as many other learners around, basically. I know when I started my attending practice, I wasn't that great at ortho because every hospital I'd worked at had an army of ortho residents running around, and they were popping those hip backs in, they were fixing those trimals all by themselves. And when I came down south and I worked with some of the clinicians that I still work with, I was amazed by their clinical skills. I was amazed by their lack of reliance on consultants, both from a procedural standpoint and from a medical decision standpoint. So I think one of the benefits is that you're not in as much competition for other learners when it comes to procedures in most of these community-based programs.
Well, I think we touched upon it a little bit. I do want to, I'm going to hop around a little bit too, if that's okay. Can you guys talk to challenges, to things that you think are different? And it was touched on a little bit, but hoping to kind of address those. And I think we've kind of it's shown that there's a variation between programs, and of course this is a bit of a it's people that we knew and heard of. So of course I think it's important to draw the distinction that there's probably programs that aren't doing as well out there that are sponsored by for-profit entities that are not represented on this panel. But overall, the things I was hearing were pretty positive. But talk about challenges for me, specifically as they relate to the for-profit. Either hospital ownership or the faculty group structure.
I would say probably one of the biggest challenges working in some of these institutions specifically is kind of that ladder of how complicated is the system, right? In the sense that as a program director, I have different bosses, right? I have my ACA hospital is going to be, or my for-profit is going to be on top of me. Then I have the corporate management group that is on top of me. I have medical directors on top of me. I have the DIO that's on top of me. So I report to basically half of the world and their mothers. And that actually makes it somewhat complicated. But at the same time, since I have so many bosses, nobody knows what I'm doing. So I can definitely work some of the details under it and make it a little bit easier. I will say that when we started our program, and I'm not going to say that it was easy, right? I did have a lack of faculty. And the main reason that I have that is that everybody says, hey, let's start a program in a rural place. Who wants to be, from their room, please, who wants to be in a rural place by themselves and not practicing with anybody else, right? Very, very few people are going to raise their hands, right? So our hospital is a little more, at the beginning it was more rural, now it's exploded and there's people living there because of COVID, right? People started moving outside of the city and getting closer to us, right? But that's one of the challenges, right? Getting faculty there was kind of a little bit of a challenge initially. And obviously in a system, now we have been 6 years on the program, but when it started we didn't have all the resources, right? We have to grow some of those resources, and I think we have done a better job now because now the programs just don't start, right? We have to go through a process and make sure that everything is there.
Yeah, some of the challenges we've faced is, everything is a little bit of a double-edged sword. So while we're a large group, we have over 100 physicians and 120 mid-levels, and 12 facilities essentially. We can spread our residents out, but that becomes a challenge when the residents aren't working with the same attendings all the time. So they might meet, one attending and only work with them for that entire month. So then getting those the feedback and the evaluations of the residents is a little bit more difficult, and I think it makes the residents sometimes feel a little bit uncomfortable. They're not familiar with the attendings. I think they've done a really good job of making their schedule so that when they see, because our schedule comes out first, and then they can put their residents with the attendings that they know teach well. So I think that's helped. But it is a bit of a challenge when you have such a large group like that, and getting that onboarding of who, really it was UHS said, we're starting a residency. We went, huh? And then there it was, and we're like, okay, I guess we're all going to be teaching physicians now. So there's still a few that are really kind of not wanting to do that. So that's kind of some of our challenges too.
Oh yeah, Steve, go ahead.
I think that also on a recruitment level, some of the med school-based areas sometimes sort of put a bad name to us and give us a little bit of a stink, like there's something wrong with being part of a CMG. Like it's almost like, no, the true and tried is the large academic centers, and that's the only place you should be in. And that could be something, right? I trained at a place like that. I know the attractiveness of that, but it is something that for recruitment of students, we have to have a balance. We have to have a balance to say, there's like, just like I may want to go to a trauma center, I may want to go to a community place, but they're different. They're depend on what you're expecting, what you want to get into.
I would add one more thing too, which is it's kind of nuanced, like you alluded to before, Martin. So we are team health, but team health has absolutely no role in the governance or the management of the physicians who see, or I'm sorry, of the residents who see about 85% of our patients at our main facility. So team health, who's used to managing physicians, has no governance over the residents who are seeing all the patients. And HCA, who traditionally has not been used to employing and managing physicians, is managing the residents. So it's a very nuanced concept. And it can be a little bit difficult to navigate that kind of complicated hierarchy of kind of physician governance.
Jen, while you have the microphone, there's this concern that, residents, are, especially at these kind of for-profit institutions, might be cheap labor. I kind of threw out that word earlier, or cogs in the wheel. And, the thought that, one, not just how that impacts their clinical experience, but how that might impact their wellness, so to speak. So I'm going to pose a question for you. Are your residents well?
Well, are you guys well? Do you guys feel well? They feel really well right now. Thank you for coming out, guys. So, it's interesting. In full transparency, Martin and I just attended a 2-day faculty development workshop on wellness, and this is in a series of workshops that HCA has put on with wellness. And every program is very different. I know at our program, we have really put an intentional focus on promoting autonomy, competence, belonging, and growth, which are, the 4 key pillars of wellness. So I can't speak to all, programs represented by this group that we're discussing here today, but I know that we are not alone, and HCA at least has put a very strong intentional focus, not a superficial, go have pizza parties, but a real intentional focus on creating a culture of wellness so that your residents can learn in an optimal environment and really grow as physicians and be humanistic in their care.
Thank you. I'm going to put up, sorry, you're going to see me fly through some of the questions. I'm still going to ask maybe some of those questions, but I just wanted to put this up there because I know we have about 10 minutes left. So if you have questions for the panel, the QR code's up there. Feel free to shoot questions in. Some of the things I kind of flew through just while we're getting questions, if people have them, is the DIO perspective. Maybe we'll get the DIO perspective, Jason.
So yeah, I can give a perspective from a DIO standpoint. So our hospital, I would say it's like a moderate-sized sponsoring institution with about, we have 9 residency programs and 3 fellowship programs. And even within our single institution, we have a lot of different employment models. So Like I mentioned, our EM group is a large Democratic group. We have a couple single partnership groups like our ICU group and our trauma group. We have a neurology group who is actually employed through the medical school. And so even within our single institution, we have a lot of different kind of models. And in terms of the quality of the programs, I mean, we have some programs that are really great quality in my mind and some that maybe are struggling a little bit. And for me, it has nothing to do with the employment model whatsoever, and I think it has everything to do with leadership. And so what I find is that, the programs that are doing really well and are high quality tend to be the ones that have great leadership structure in place. And they create great cultures, and they have really happy and satisfied residents. And so even within our single institution, we have a lot of different models, but it really is dependent on leadership. And I think what I've seen is that a lot of the groups like Vituity and HCA, they're really focused on leadership development, growing program directors and DIOs. And I don't know if someone wants to talk about like the EM work group that we have through HCA, where a group of EM program directors, we get together on a monthly basis. And so, I don't know if someone wants to
So
talk
again,
about
obviously, we said about the things are complicated and can make it difficult for us, but at the same time, you also have a different side, right? I would say we have a monthly meeting, all PDs. We have about, right now, 19 programs. I think it's going to be 20 programs outside there that all the PDs and APDs can actually participate. So that also means that there is opportunity for bringing issues in one institution that is basically in another institution, right? Like the same thing that we're doing right now, if you actually are going to take anything out of this conference, it's going to be the network that you're causing on it, right? So we have created like our internal network, and we actually go through kind of questions and answer of that, right? By the way, I was going to add one more thing about metrics. If anybody is interested in doing research, look for metrics and how they impact education. I did a literature search, I couldn't find anything. I actually found efficiency, but nothing about metrics. So if anybody wants to play on that, I will give you a shout out because that will be something to talk about.
So I have a bunch of questions that are coming in. So I just wanted to start fielding them, if that's okay. Maybe one person for each question, just so we can try to get through as many as possible. There's several questions regarding faculty, and one, how do you protect their time? Like, is that paid or not, or is volunteer? And then also, how do you, kind of related to that, is how do you motivate clinical faculty to do scholarly work, and promotion ladder? So that's a multi-part question, but if you want to break that apart.
I'll break that question in a couple of things, right? We currently, so part of one of our structures is that we don't have a tenure track, right? We are associated with a medical school. We do get assistant, associate, and maybe professor, but it's not for tenure, right? So it's not that I can retire and I'm going to be like dean of whatever of USF, right? That doesn't work like that. Now, the part for faculty specifically, I can give you kind of a hint, right? Each of us is going to have a different model. I will tell you right now, our model is I protect the time for my faculty, right? My faculty do not work a certain amount of hours. That work that they ask, they get a stipend, and I reduce that from their time of clinical work, okay? That was the model that I decided to implement because I wanted to have a more engaged faculty. We do pay for faculty development. AC has created a bunch of, we even send them for the competency for feedback. It's an ACGME kind of required, and they get that completely paid for going to that, right? But I'll tell you, it's a little different in every place, right? So our faculty, for instance, on ours, I protect the Wednesday nights and the Thursday because that's where they're going to be presenting to our residents, and they get that stipend and time to be able to do research and everything else.
Yeah, if you want to unpack any of that,
yeah,
too.
with ours, it's a little bit different. Our faculty do get a monthly stipend, similar to that, and then they get a scheduling preferences. So in terms of the scheduling, they definitely get a preference over the other physicians on what schedules, and that's kind of their bonus. As far as research protected time, they get paid in protected time if they present, but otherwise the research itself is not necessarily paid other than out of their monthly stipend that they get.
And Christine, just one more question, kind of who is responsible for and how are didactics delivered to residents? And is that time like included in the protected time or, yeah?
Yeah, so it is included in the protected time. It's included basically with the stipend that you're expected to attend at least one conference every quarter. And because we have so many physicians, we can spread it out a little bit amongst the docs. They're not expected there every week, but we do have a few that like to come every week, and they do come every week. And so they are paid to show up to conference. And then when they give a conference lecture in our conference, they're paid for that as well. But we also, because we have 3 residency programs in Las Vegas, it's been nice we collaborate with the other residencies. So we just present what I would present at my program. I just present at the other program, and then you can actually put it down as an ACGME visiting lecture. So it's really worked out for our 3 programs to really kind of support each other. So that's been great.
I would say for in our setting, it's a little bit different. So I require my faculty, because we're small, so we only have 6 residents per year. I do require them to be 75% of the time in academic activities. That's part of their protected time, so they don't work Wednesday nights or Thursdays. So my expectations there, if I'm going to be protecting that time, is that they can actually spend time with the residents and teach them. I'm pretty sure that everybody else is a little different here, but again, it depends on how is your structure and how you work on it.
So let me just interrupt for a second and ask a couple more. There's one I can kind of clarify, I think. What's the best way to identify a CMG-run program prior to interviewing? I'm not sure if that's from a resident or faculty perspective, but the same way, Ivy clinicians, plug for Alderman's website, it lists the hospital group, or the faculty kind of group, the EM staffing group, as well as the hospital owner as well. So if you desire that information, you can get that there. Let's see, what protection do residents have from contraction, consolidation, bankruptcy of the corporate group? And I don't know if that's the corporate group that's the faculty staffer or the hospital, but so you can.
Yeah, I mean, certainly when Envision went through their bankruptcy, we didn't notice anything, in all honesty. The residents wouldn't have been impacted at all because the residents are employed by UHS. So I'm not sure, I guess what would happen if UHS went bankrupt, but when Envision did, obviously didn't affect them at all. It didn't even affect us. Our group is still with Envision. It's been the same. So I'm not sure.
But if a hospital goes into bankruptcy, there is a real risk that the residency programs will be closed. And that has already happened. In Virginia has happened. Even places like in Corpus Christi, like I'm going to tell you, they were like going through some difficulties that they were not really in bankruptcy, but they were going through there, and that's some of the decisions that they have to take, right? And again, I'm just naming a few, not because I'm just saying something specifically, right? But there is a real risk that if a hospital closes because they cannot continue going operations, they have to probably transfer the resident and they have to go somewhere else.
And I think that really highlights what we've been trying to delineate here, which is the difference between the CMG and the hospital. So, typically when a CMG loses a contract and someone else gets it, most of the attendings will stay and sign on with the new group. That's usually what happens. If, for instance, at our site, if Team Health was out and Vituity was in, they would most likely hire all the same attendings. And it really doesn't affect the residents at all because they are employed by the hospital, as Al was alluding to. Now, if HCA went bankrupt, that would be a big problem. But the CMGs, there's really not a lot of relationship there, to be honest.
What can any of you comment on concerns that residents will be less prepared or qualified to work in a large academic center if they choose to do so after residency? How do you expose them to that style of practice? So contrary to. Yep.
So I can say, having trained at a 4-year program with the intention of teaching at a 4-year program, training at a 3-year program from a clinical standpoint, from an intellectual standpoint, I really don't think that you're missing a whole lot. I don't know if that's going to be a popular answer, but that's my feeling. My fantastic APD, who's also here with me, also trained at a 4-year program down the road from me in New York City, and I think she shares my opinion on that.
Yeah, I don't think that, I think the biggest difference is are, at the community hospitals, there's less support. And so the biggest difference is realizing, oh, wait, I can call OMFS because they're actually here. Oh, I can call ENT because they're actually here. We don't have those services at our facility. So they're actually, I think, almost more prepared because of that.
I was going to ask on that. I have fellows that have gone to, like, if you do a fellowship, you end up going to one of the bigger academic centers. Now you're going to be kind of a faculty member and just try to work on that specific scenario. I think that the difficulty there is adjusting your style to how the program works there. What does that mean? Well, if they say that for every fracture you have to call ortho, guess what? That's going to be your new style, right? You might feel comfortable that you can do the ortho maneuvering or you're going to be doing the dislocation, but that is their policy, right? Because they have other learners that they need to train. So I think from residents I've gone to do fellowships, that has been their why am I waiting 5 hours here for OMFS to come in if the patient's not going to do anything for the patient, right? That has been some of their frustration, or they become a little more cavalier and they charge people that they wouldn't otherwise do, right? So I think that's a style that you will have to learn.
I got a couple other questions. I know we're kind of running tight on time, but I want to make sure I field as many as possible. Let's see. Stipend is not equal to FTE equivalent protection. Can anybody clarify that?
You're always going to subsidize the work you're doing. I think if you went into academics for money, pick again. I think that's been the finding.
That's all for us. I would make more clinically. I think everybody here would more clinically if we actually have stipend now.
Yeah, we definitely would make more clinically if you didn't teach. So yeah, if you're worried about making a lot of money, teaching's not the place to be.
That's not the way to be.
And then kind of, let's see, there's a question about how it sounds like faculty get to choose to teach or work with residents. This, maybe there isn't a complete buy-in from some groups that are training residents. How does that work?
Yeah, so I think each structure is going to be a little bit different depending on how large it is and where it is. But yeah, for our group, our structure is we have enough facilities where residents don't go, that if faculty do not want to teach, we put them at specifically those facilities where there's no residents, and then they don't have to teach and they don't have to be involved. And so we keep the ones that do want to with the residents. So it really is going to depend on how big your group is and how much flexibility you have.
Like, for instance, we do pay a small stipend to the teaching faculty, but their expectation is that they are going to be teaching, they have to present a certain amount of times a year, and that not everybody does that, right? So everything here is going to be a little bit different. That was something that we actually negotiated from the beginning of the program. But they are required to attend a certain amount of lectures a year, and they are supposed to present a certain amount of time and do their evaluations.
So I'm going to kind of wrap up there and let the audience transition. So kind of in conclusion, I think what came out of this, and hopefully is that there is substantial heterogeneity between programs. The conversation is a bit more nuanced and varied versus bad versus good. I think that there are pros and cons to each of these training environments, and perhaps some feel like the cons are much larger than the pros for some, and again, we have kind of a selected group here that's presenting as well. So it's certainly not all programs will be as flourishing perhaps as these. So that's also important to know. But I think there's trade-offs. And I think there's need for further study. I wouldn't be a researcher if I didn't say that. So I do strongly believe it, though. Thank you all. Appreciate it. And thanks to our panelists as well. Thanks.